Can we, after welcome you all, can we?
Thank you very much. I am very honored to be with you today. I have bring greetings from my team from Kenya, where we've been working with implementing mobile health solutions. Our particular area of interest is to support the frontline primary healthcare workers, the nurses, physicians, primary care physicians especially, so that they can deliver the best care possible to the patients with the resources they have available. My objectives today are to survey some of the challenges and barriers in accessing clinical decision support information so that best care and education can be delivered with the patient at the point of care. We'll want to review the challenges in design and development of the Digital African Health Library Service that we've been developing over the last 10 years to meet this challenge, and then discuss some of the challenges of implementing the most recent version. Let me just see if I can share the my screen with you. The genesis of the problem for need of mobile health solutions is that there is a significant issue of health resources. In Africa, where I've served for 16 years, Africa shoulders 25% of the global disease burden, with only 11% of the world's population and only 3% of the health workforce and just 1% of the healthcare resources. You can see that there's also a huge issue of workforce emigration, where almost 30% of the healthcare workers that are trained by African countries migrate to other areas and are not staying to serve in their countries. This becomes a real issue of health resources when the needs are so great. I've alluded at the bottom to show that the rural doctors that come from the workforce are actually quite a small minority. And so you can notice that in the Kenya situation and across sub-Saharan Africa, we have a problem of out-migration of our health personnel that have been trained at ministry expense. And so few of the, only approximately 3/4 to 2/3 of the personnel remain to serve. Next. So this then becomes a problem with the numbers of people in the workforce, but also a maldistribution. As in Bangladesh, Kenya has 80% of its population living rurally, yet only 20% of the doctors serve in the rural areas. The majority of those are the ones serving their 2-year Ministry of Health obligation in district hospitals. The majority of those 20% that are urban dwellers in the cities like Nairobi are also poor, and yet the 80% of the doctors that are serving them are often more likely specialists and serve a minority of the city residents who are not poor. Next. So what are the strategies to try to meet these incredible disparities of health resources? Well, the first, and the one that I've been working with during my career, is to try to help redistribute practitioners by training those who can serve the district hospital system by focusing on training primary healthcare workers. Specifically, I am a family physician with the specialty of family medicine, and have been helping set up family medicine residency training programs with the equivalent M.Med degree in our system in Kenya, so that they can serve specifically in these areas and be trained for them. This becomes the main strategy for making a difference for the distribution problem. But even with practitioners in the area, what is needed to help support them? Well, what is available, of course, both resource in personnel and material must be used wisely. And we feel that the practice of medicine needs to be informed by evidence. Next. The goal, starting in 2009, in developing the Digital African Health Library, was how can we best use evidence and bring evidence to primary healthcare workers in rural areas where these resources are scarce, so that what is available can have the most benefit. Next. We did our background and literature review, and 3 themes emerged from that work. We wanted to know, how do primary care clinicians access information to answer the questions that are prompted by their patient care problems? We wanted to look at what are the disparities of health information availability and the barriers to use of this information. And we wanted to look at the potential leapfrog of mobile technologies to bring decision support information to the point of care, where a practitioner can answer questions that are posed from the patient care problems that they faced. Next. So in 2009, a study was done using 8 family medicine registrars that were actively involved in patient care at 2 different hospitals in Kenya, with the objective to find out if the availability of offline point of care resources could affect their plan for care and the patient's clinical outcomes. This becomes the bottom line. Can we improve patient care using technologies that bring information closer to them so that they can consult resources in an offline manner, not dependent on the internet? Next. We repeated this study in 2018 after developing some of the aspects of the digital library. We enlisted the help of 15 family medicine residents in 3 teaching hospitals, but instead, from the developments, we had a new integrated mobile phone-based app that could be on both Android or iPhones. We added local Ministry of Health guidelines, and we'll talk about the importance of policy to make those available. We had improved internet, of course, over those 10 years, and had more resources to offer our subjects. Next. The study instrument, I'll go through this quickly, was to look at what subject the doctor was looking up, whether they used a consultant, what format they were using, what category of resource, including colleague, database, formulary, guideline, handbook, journal, or textbook. Next. And we looked to see how well did the use of a resource answer the question, did it alter their prior plan for care? In other words, did it make a difference? Why would we want to have information available to people if it didn't help the patient have a better outcome? Then we wanted to know, where is it used with the patient at the point of care, or is it in some other site? And especially, when was it used? Is it helping the patient, or is it something they're looking up later when it can't impact care? And lastly, if there's knowledge gained but it couldn't be implemented, are there barriers to the use of information this way? Next. This is just a quick slide to look at the studies of the subjects of the query. You can notice that the main specialties are represented, mainly medicine and pediatrics, but also a smattering of other subjects that were looked up in the mobile device. Next. From the 2009 study, you can see in the blue bars before we allowed them the use of mobile information, most of their information was gained from textbooks in print, in the print form. But after the ability of resources coming to them on their phones and devices, they could get almost 40% of their answers from the information presented on the mobile device. Next. So here you can see the differences between the two studies. That PDA and phone using offline was 40 to 30%, but you can notice the big difference in 2018 because internet had improved so much. Many were able to gain access to information through their device directly off the internet, almost a fourth of the time, versus the 2009 study where you can see over a third of the time they were using print materials is almost gone now by 10 years later with the improvements in technology. This is the difference that can be gained by making both the technology and the access to relevant information available to healthcare workers. It can make a difference at the front line. Next. Here's just an overview of the category of resources that were used. Once integrated database information, such as UpToDate, or in this case, Dynamed was available. It can be accessed and easily used. Next. The categories of resources you can see between the two studies. Integrated databases were available and utilized over a third of the time. Another large difference between the two times was we had guidelines available from the Ministry of Health and other sources, which are very easy to use by front-line healthcare workers. Colleagues remain, of course, an important source of information, especially for learners, as they are being taught on the wards or in the outpatient departments. Next. Our large, one of the main interests of our study was to find out whether we could facilitate getting answers to clinical questions right with the patient at the point of care. And you can see that with development and enabling of mobile technologies, we are able to improve that to a considerable degree. Now to the point of almost half the time, the study participants were able to answer within just a few hours with the availability of portable devices. Next. Did the information change the plan of care? None of this matters unless it can make a difference. So we have to look at, can the information change the plan of care? Yes, it can, significantly in a fourth. And when you consider a change being made in the plan of care in over half of the questions asked, we think that that can make a dramatic improvement in patient care if the practitioners are willing to look up new information when their patients are prompting that query. Most notably, in 2 to 4% of the time, the participants felt that what they learned by looking something up at the point of care actually changed their plan enough that the patient had a different outcome from what they had expected to be. Next. So the goals from the original study in 2009 for the Digital African Health Library were to create a platform that was portable, where you could bring the information to the point of care. We felt that the internet connections in large buildings, especially if they're reinforced concrete, It interrupted internet signals to make that unreliable, so we wanted the resource to be offline. We wanted a single search engine so people could find resources easy and not be frustrated. We wanted it to be easy to set up, make it updatable, and especially as possible to bring in local resources and have permissions from the Ministry of Health and other regulatory bodies for use of local information in the resource, so that the local work that had been done to create best practices could be incorporated. Next. So now I'd like to just move to the theme of the conference, and that is, what are the challenges? We want to look at the design challenges of across the area, and that include both the technical and regulatory, as well as the human challenges. Next. So design challenges are around several different categories. First, resources. We wanted resources to be evidence-based as much as possible, because we felt that best evidence is what can give best care. But there's not so much evidence that is sourced from Africa, from our local context. So our goal was to access African journal literature and make that available. We wanted to access a specific resource called Dynamed, which is published in the USA and available in the Western market, but at a significant cost. It reviews the journal literature and puts the synopsis of published journal literature in bullet point form that makes it easy for you to scroll and review it. The Handbook of Medicine for Low Resource Settings is also another very condensed resource to make most practical upfront decisions easier. Another resource challenge is that we, back please, is that we want it to be at point of care. Most resources that doctors use are textbook based, they're narrative form, and that's hard to scan at the point of care to find an answer. So we wanted to use a resource like Dynamed that was bullet point, and that's easier to review. Handbooks and guidelines are also usually in simplified form, and you don't have to read a lot of text to find an answer. Next. So another design challenge was to engage our Ministry of Health. I'm not sure the situation in Bangladesh, but in Africa, most primary healthcare workers respond best not to evidence, but to authority-based advice, namely using Ministry of Health guidelines, their authority for what they ought to do in different situations. And this is a good thing, because these guidelines are, of course, prepared studiously by experts in the field, using best evidence and using with the resources at hand in mind. So we wanted to access these countries' guidelines where the digital library would go. Also, Ministry of Health guidelines are on the web and usually available now in PDF form, but we needed to be sensitive about the public material that is available being brought into our resource, which is proprietary, and we wanted to get permission from them. And so where we access guidelines, our intention and we have been successful in Kenya to get what are called letters of no objection, so that we maintain good relations with our Ministry of Health colleagues. Next. Another design challenge is the sustainability. how do we sustain efforts like this? So the revenue stream for our startup could have been a pure private equity type investment, but we expected and in fact have noticed that the timelines for development are very long, and therefore very difficult to expect investors to see return quickly enough for them to want to engage. So we have used generous donations from resource partners, but even with that, trying to give a return to our resource partners, the first version proved that in trying to create a market for this material, we were not able to return enough to our resource partners to make it viable. The expectation in the market for African users is that it ought to be nearly free, and that makes the margin for ability to return something to our resource partners, the people supplying, the publishers supplying material, makes it difficult for them to expect much at this point. Tech donor startup funds were used then, that people that were wanting to invest, our partners are Grand Challenges Canada and Spider from Sweden. Each tech partner, of course, has their own goals for their investment, and we of course are doing our best to try to match their goals with ours, so that we can move forward. Our tech partner in Dextra also donated considerably their some of the costs that they have in producing the product. Next. So the sustainability for the future is an attempt to try to engage African users for the value of what they're receiving. The goal being that if something is completely donated by donors, will it actually be valued and used? So we've been asking our product to be purchased at a subscription rate of $10 per year, which is a small fraction of the approximately $1,500 value of materials that are in the library. We may need further infusions of donor funding to move things into the many countries across Africa, and the costs of engaging ministries of health. We thought about using telecom resources. The telecoms in each country, of course, are eager to get digital solutions out there, but of course their incentive is to engage users with using data services that are then feeding their bottom line. Since our intention is to use offline resources to minimize the disruptions, there would be very little incentive for telecoms to get involved. The other major source that would potentially be available to us are pharmaceutical companies that would buy advertising within the resource. They're more than willing to do that, but as a matter of principle, we have felt that since we're talking about trying to bring better services at the lowest cost, the advertising is by intent to go to use higher cost services. Next. So implementation challenges very quickly. Our technology. Next. Next. The partners that we had changed their app, and we have challenges with local IT capacity as well, that setting up our payment systems and our support devices. Next. We also wanted to add the ability to bring PDFs into the XML world of our app, and that proved challenging to give more availability to the Ministry of Health guidelines. Next. We had implementation challenges also with the learning culture. This becomes one of the major challenges for bringing mobile health solutions into use. Next. Next. We next one before, professionalism. Professionalism is the expectation that that the users of information will want to use it, will want to get learn and be able to incorporate new information into their practice. However, many professionals that are graduating regard their qualifying degree as the endpoint of their learning, and the NGO culture that is typical in Africa will pay clinicians to attend seminars about whatever they're interested to present, and that payment for learning then disincentivize the professionalism that a practitioner should have to want to learn for the sake of improving their care. So the compassion ethic to work in underserved areas is also an important issue for trying to meet these huge disparities. Next. Another cultural change is using evidence. The method of learning in most of our settings in Africa is based on the authority of the professor, which of course in most situations is from the wisdom of a lot of experience. However, when new evidence comes out, practice needs to change, and the ability of a learner to challenge authority with evidence, of course, is very rarely encouraged. So the goal needs to be providing resources at the point of care so that all can discuss and agree what the latest evidence is and make decisions for best care. Then lastly, knowing how to access, interpret, and use evidence is an important thing as well. Next. The last culture change is that the expectation in using just-in-time information. Medicine has created expectations for lifelong continuous learning, but the evidence for listening to conference seminars shows that it does not change or improve practice. So there needs to be an awareness that evidence being created by the patient care problems that are prompted by clinical care are of high value to help a practitioner learn new information and thereby change their practice to the latest evidence. Next. So I'll just skip through the digital library now. As of this month, is being launched in a new version to help increase the number of resources, make it selectable for downloading, incorporating the PDF so we can get the Ministry of Health guidelines in there, as well as journals, and including a medical dictionary as well. Next. This collaboration then is between Indextra and the Digital African Health Library and many other resource partners. Next. And includes over 50 different handbooks and other resources that can be utilized. Next. And next. So our distribution is through all of Anglophone and Francophone sub-Saharan African countries, and hoping that institutions will also be willing and interested to bring this to larger groups. And with the automatic updates, we can keep it current. And the availability of a background audit will helps us know what titles are being used, so we can be sure that we're meeting the needs of our customers. Next. So we want to thank the many partners that we have that have made this possible, and generous contributions, especially from our content partners as well. It all comes together as people are willing to work together to meet these huge disparities and needs. Thank you very much.